diabetes as well as kidney disease. These are the very low LDL targets, and these are some of the important changes in the recommendations. Ezetimibe is now a class 1A indication in addition to statins if the goals are not reached. Furthermore, the PCSK9 inhibitors are recommended in high-risk patients if the goals are not reached with statins and ezetimibe. And now there's also a further decrease in LDL below 40 milligram per deciliter when a second cardiovascular event happens in patients with cardiovascular disease in a certain time frame. And furthermore, for the high TG levels, now the statins have a class 1A indication. What are the basics for these new very low LDL goals? These are mainly the three studies I will focus on later. Moreover, IVUS studies demonstrated that with the LDL of 70 milligram per deciliter, you might stop the plaque progression, and with the LDL below 55, you might even achieve a regression of the plaque burden. Clinically, we know from many studies, here are the results from about 200 patients, that especially in patients with a very high risk, a marked LDL reduction leads to a substantial reduction in cardiovascular events. But how is the reality? A cross-sectional European study that Avenchi Registry shows that the vast majority of patients did neither achieve the treatment goals in 2016, these are the solid bars, nor in 2019, these are the dash bars. How can we become better? We have several new treatment options I will discuss with you in the following slides. However, with the more potent statins like rosuvastatin and atorvastatin, we can already do a very good job with LDL reduction up to 55%. With ezetimibe compared with simvastatin several years ago, LDL of 54 milligram per deciliter compared to 70 milligram per deciliter with at that time simvastatin alone was achieved in the IMPROVE-IT study in patients after an acute coronary syndrome. And it could be shown that especially in patients with a very high risk profile, that these patients did benefit from these very low LDLs. We get now new treatment options thereafter with the so-called PCSK9 inhibitors. Here you see the complicated term for this abbreviation. How do they act? The L receptors bind to LDL and remove the LDL particles. Recycled LDL receptors then return to the cell surface to repeat this process. PCSK9 binds to the LDL receptor and promotes their degradation. Inhibiting PCSK9 increases the availability for the LDL receptor to move again the LDL cholesterol from the circulation. You see this came here on the left side in the presence of the PCSK9 receptor. PCSK9, the LDL receptor, is degraded in the lysosome. But in the presence of an inhibitor, this LDL receptor can be recycled and returned then to the surface to bind more and new LDL cholesterol. There are two landmark studies showing that this worked. The Fourier trial with evolocumab decreased the mean LDL to 30 milligram per deciliter over a period of about 3 years, leading to a 15% reduction in the primary endpoint. The Odysseus outcome trial with alirocumab showed a marked reduction in cardiovascular events, especially in patients with atherosclerosis in 3 beds. Again, these are the high-risk patients. Bempedoic acid is quite new in the market, at least in our country. How does it act? You see here the different steps of cholesterol synthesis in the liver. Bempedoic acid blocks the ATP citrate lysis, an enzyme that is not present in the skeletal muscle, and thus avoiding the most common side effect of the statins. The Clear Harmony trial with bempedoic acid lead to a further about 30% reduction in LDL in patients with a maximum tolerated statin dose. In another recent trial, the combination of bempedoic acid with ezetimibe led to a 35% reduction in LDL cholesterol as well in the high sensitive CRP. I think this combination is an important treatment option in patients not tolerating the statins at all. A quite new approach to lower the LDL is inclisiran. Inclisiran is a so-called small interfering RNA. How does it act? To make the story short, it inhibits the translation of protein PCSK9 and by this increases the number of LDL receptors. The application of this new drug is easy. After an initial phase, it's applied only every 6 months subcutaneously. Orion 10 and 11, Europe and US and South Africa, were the phase 3 studies in CED patients. And with a mean reduction in the LDL-C levels of about 50% over 540 days, the effect seems to be similar to the PCSK9 inhibitors. One new approach for patients with high TG levels, the launch will be in Europe in the next months in September, with high dose of icosapent ethyl 4 grams per day. This is a trial, a 25% reduction in high-risk patients could be shown over a period of 5 years, both in primary and secondary prevention. Now, how to reach these LDL targets we have now from the ESC. With the potent statins combined with ezetimibe or bempedoic acid, we might achieve a reduction of up to 65%, which is sufficient in many patients. Adding the PCSK9 inhibitor, or maybe in future is inclisiran, in combination with a statin or ezetimibe, we might even reach a reduction of about 85% in LDL cholesterol. Many people have concerns about these very low LDL-C levels. But at birth, we have average level of 30 milligram per deciliter, which slowly increases with age and then high fat diet. Thus, these low LDL-C levels cannot be harmful. What about the new onset diabetes? There's only low and clinically non-significant increase with statins, but this is not observed with the PCSK9 inhibitors. How to reach the LDL targets now in the daily practice? Statins and ezetimibe remain the basic therapy. And now use the high-potent statins such as atorvastatin and rosuvastatin, and in the patient with a high risk, start early with ezetimibe. The new therapeutic options are mainly reserved for patients who have side effects under the basic and the conventional therapy, and they are reserved for high-risk patients not reaching the targets with the basic therapies. And very important, inform the patient and the family doctor about the treatment targets. This will increase the compliance. Thank you for your attention. Okay.
Thank you very much, Volker. Are there questions? Yes, I have some question for Professor Klauss, please. I have two questions. The first is the statin is not indicated for the patients with heart failure. But if the patient has a heart failure and a atherosclerotic cardiovascular disease, and we have to reduce the LDL cholesterol, in this case, the coenzyme 10 has any role? Can we combine it to statin for the patients?
I didn't get the whole
coenzyme 10.
The bempedoic or the?
No, the coenzyme 10 combined with the statin for the patients with hypercholesterolemia.
With heart failure and ischemic heart disease
Yes, that's right.
Okay. Actually, I don't know the data for that. I see that a lot of patients got the coenzyme Q, but actually, I'm not aware of of any random trials regarding this issue, and also regarding any hard endpoints. Maybe you have more information that I don't have. We see it sometimes that the patient got this co-medication, but actually I'm not aware on any randomized trial, especially in this patient, indicating an additional effect. I think, of course, we have to we discussed it in the last session already, that in patient with ischemic heart disease and heart failure, there are many diseases in one, and I don't know exactly, or I think we don't know exactly how much we can really influence the already progressive the ischemic cardiomyopathy with the statins. But on the other side, if LDL lowering is feasible with the instruments we have, of course I would try it and also get to this the lowest LDL value possible. Yeah.
And the second question is, in some patients, especially in the female patients with a hypercholesterolemia and hypertriglyceride, and when we put the statin for the patients for a while, the triglyceride increase. So in this case, what is the solution?
Yeah, sometimes it's a question what is the reason now for the high triglycerides in this patient? Do they have additional diabetes, which is most often? Otherwise, I think in most of the patients, when we redo the blood samples and the patient come in a fasting condition, then in many of these patients we have the lower TG levels. And of course, it's also a question: is this for primary? Is a primary indication for primary prevention or for the secondary prevention? So if the patient is at risk, I would of course start with the statin, because for the statin and the LDL lowering targets, we have most of the data, and I think then later on changing and discussing with the patient lifestyle, nutrition, everything, we might also get the DDG downs, and maybe in the future, as I saw short in the last slides, with the new drug not yet on the market, and we don't have any appearance to that with the high dose of the omega-3 acid, this might be an additional option for this patient with the high cholesterol and the high TG levels.
In these patients, can we combine a low dose of fibrate with statin?
Yeah, I think it is still an option. I didn't show that because we only rarely do it, and most of the patients coming with this kind of combinations, they are treated in the special outpatient clinic on the university. The patient with a really high lipids and high TGs, they are normally treated in the outpatient departments for high lipids in our university hospital. So especially these patients with this combination, we do rarely see in our daily practice. But of course, it's still an option to get down. But I think the with the newer statins, especially now the availability of the rosuvastatin as a generic drug, I think we have much more options also to treat the other, get them down, and only in some patients we need these so-called older drugs for the TG reduction and LDL reduction.
Thank you, Professor.
Hi, can I have a question? Hi, Professor von Klauss.
Where are you?
Yeah, I'm fine, thank you.
Nice to see you
Very
again.
happy to see all of you in good health.
Yeah. Same to you. Yeah.
Thank you very much for your interesting presentation. We have received many news from your lecture. So can I have a very short question concerning about the usage of PGS.TS?
Yeah.
Can you use this drug as first-line therapy in a very high-risk coronary patient? Because normally we use first as starting with high dose, but in case of very high-risk coronary artery disease, can you use as a first-line therapy immediately? PGS.TS.
Yeah, so I think it depends on the health system. So especially in our system in Germany, before we start with PCSK9, we have to show that we could not reach the LDL target with both statin and ezetimibe. So we have to do a documentation of the LDL values and the possible side effect of the statins. And when we have documented that the patient did not reach, there's somebody in the background. Okay. And when we have clearly shown that the patient, high-risk patient, could not reach the LDL target with the statin and combination with bempedoic, whatever, then we can start to prescribe the PCSK9 inhibitor. So that's the way we do it, and also I think we should do it because this medication is quite expensive. And on the other way, we see when we take some time and start and increase, for example, rosuvastatin slowly over time, that in many patients we can get this 55 milligram per deciliter without a PCSK9. So we have to take some time, and especially in our system, we might not start in the beginning with this patient, but of course, if we do not reach, let's say within 2 or 3 months, this target, then we start with a prescription of the PCSK9, but we don't use it as a first line. Yeah, normally not. That should be the exception. Yeah. Okay. Are there more questions?
Giáo sư Huy, Trần Văn Huy có câu hỏi nào về rối loạn lipid máu? Hỏi cho vui. Mở micro. Huy chuyên gia lipid đấy, nhà lipid học.
Professor Huy have a question. Yeah. Professor Huy.
Huy, đấy. Huy ở Nha Trang, anh Quang chào là hỏi. Mở micro. Huy ơi, mở micro. Rồi.
I would like to ask each Christian in European EMA accepted each Christian for usually daily.
Oh, sorry, I didn't. I couldn't understand for the quality of the.
I would like to ask the English do usually in Delhi for hypercholesterol.
Sorry, I didn't get the.
He wants to to ask about the inclisiran.
Inclisiran, okay. Yeah.
Yes, inclisiran in the treatment of the patients with hypercholesterolemia.
Okay, sorry. Okay. So the inclisiran was introduced in, I think it was introduced on our market in, I think it was in November. And I listened a lot of conferences, especially on the treating regarding hyperlipidemia. And to my knowledge, they're only starting now with the inclisiran, and there are only few experiences. So I think some of the people are still reluctant when they say, okay, every 6 months, if I have side effect, what happens? Do I have the side effect and for 6 months? And on the other side, I think when we will get more data this year and the next year, and I think it might be an alternative to the PCSK9 inhibitor. Presently, we the reimbursement for the patient is not clear, but I think this will change in this year. So presently in our country, you might prescribe the PCSK9 inhibitors, the two on the market, according to the condition I mentioned. And for the inclisiran, we have still to wait for the green light from the insurances. So up to now, the experience are really limited. But what I heard from the colleagues in the special ambulant outpatient clinics in the university, up to now they had successful treated only some patients, but yeah, without any side effect. The side effect from the studies are on the placebo niveau, like for the PCSK9 inhibitors. So I think it's a promising therapy. That the cost of the therapy is still more than the PCSK9 in our country, but I think it's a question of time until this might change in the future. Yeah. Okay.
Thank you.
Okay.
Thank you.
Okay. I think we have to. I think we have to move on now with the program, and I would like to introduce the next speaker, this Professor